Okay, good evening, everyone. Welcome to PhD 101 National Level Rapid Revision Series. We welcome you all to yet another learning deliberation, where we're going to be having a very important session by the guest speaker for today. Before I can go into the details, I'd just like to give a brief introduction and welcome Dr. Vinej Somraj to the panel. Welcome, Dr. Vinej.
Okay.
That's great to have you there, and all of us participants are just joining in. I think let me just formally introduce our guest speaker to the PhD 101 family. We have with us today Dr. Vinej Somraj. Dr. Vinej is presently working as an associate professor in the Department of Public Health Dentistry at the Raja's Dental College and Hospital, which is in Tirunelveli, Tamil Nadu. Dr. Vinej has completed his BDS from Century International Institute of Dental Sciences, Kasaragod, Kerala, and MDS in Public Health Dentistry from Venapoya Dental College, Mangalore. Is also pursuing a postgraduate diploma in forensic anthropology and odontology. Apart from that, he's also got varied interest into various areas and is also pursuing his PhD as well as his PG diploma in various other activities. Again, he has got his interest into research publications, having a total of almost 35 national and international publications, and also various important contributions in the textbooks as well for public health dentistry. So today, Dr. Vinej will be discussing with us a very important topic, which is the role of grassroots level workers in the provision of health services. That is the oral healthcare, the dental healthcare delivery system. What role do our grassroots level workers have to play? Now, as often we describe them as the primary source of contact or the primary contact of the community, grassroots level workers could be divided into various aspects. I think Dr. Vinej will be providing more insights on that. Now, just a keynote for the PGs attending this on Zoom as well as on YouTube, that this is an often asked question as a short note and can also potentially be asked as a 25-mark question for your examinations. So we hope that this presentation will be really helpful for all of you all in that direction as well. So with that brief introduction, I'd like to again welcome Dr. Vinej and thank you, Dr. Vinej, for taking our time and doing this for us. We are really, really happy that you're taking out time for our students for PhD 101, especially because we have students across the country, not just from one institution, but this is actually going to reach a lot of places. So thank you, Dr. Vinej. Over to you.
Yeah, thank you, Dancy, for inviting me and giving me such an opportunity. Good evening, all. I hope I'm audible to all of you. My presentation is just a plain blank, just words, but it will be open for discussion. You can stop me at any time or in the comment box, or you can ask the questions at the end of it. So what I'm going to discuss is like how the healthcare system, first, it's going to be in general, and then I'll come to how it is related to oral health. So when you're right, since my audience is all undergraduates
Dr.
and
Vinej,
mostly
we are
postgraduates.
not able to hear you clearly.
Am I audible now?
There's some network issue.
Am I audible now? Am I audible now?
Yes, sir, you're audible.
Yeah, thank you. So when you're writing your essay questions for a postgraduate, the first thing that you need to see about is like writing in general. What is in general? So in general, if we speak, we can call it as into various tiers. Like the first will be the national level, then the state, district, community, PHC, and the sub-center levels. So it is applicable for all types of medicine system in India. So basically the apex body for us is the Union Ministry of Health and Family Welfare. That is the apex body for us. And it is basically divided into three. That is the health, family welfare, and the Indian system of medicine and homeopathy. So basically, even though it is three departments, it is run by two main secretaries. That is one for the health and family welfare and the other one for the Indian system of medicine and homeopathy. So basically the one who as the main system is the Directorate of the Health Services, and it is run headed by the DGHS, that is the Director General of Health Services. Now, what all functions comes under the Union Ministry? What is the main thing is like that international health relation as well as the quarantine. As you all know, we have been seeing the same ministry activities for the past 2 years in relation to pandemic. So that is one of the most and the main part for it. Then promotion of research, the apex body, that is ICMR. So, and that is through research, through either for the undergraduate or for the postgraduate level, they have got various grants and everything to make sure that research happens on a frequent basis and it's up to date and adds new literature. Then regulation, that is the next important aspect. What all medicines or what all things has to be uh, happening exactly in terms of medicine. Even if it's a small tablet or anything, it has to be regulated. So we have the drug controller organization. Then establishment of drug standards. And then finally, the census. Then that's coming, let's move on to the uh, center, moves from the center to the state level. Now, when it comes to the state level also, it is the same thing. That is the Department of Health and Family Welfare, and it is run by the secretary or the commissioner in each state. It will be an IAS officer who will be running it under the ministry itself in each state, where we will be having on one focused component, that is the DHS, that is the Directorate of Health Services, and it will be headed by the Director of Health Services. So if you're looking in between, so we moved from national to the state, now coming to the district level, who is going to manage it like a middle person? Like the center and national is telling you something. Now who is going to implement it and who is to make sure that how things are happening? So it is like the district level management will be responsible as a middle level thing, and it will be organizing between the primary healthcare center on one side and the sub center on the other side. So it translates the information from the state level and the central and transmits to the periphery. By doing so, it makes sure that everything is sorted out and it goes in an organizational way so that all the administrative activities happen on a regular basis without any hindrance. Now, at district level, it will be headed by the chief medical officer, that is the CMOs or the health officer, or we call them as the DMOs. That is the district medical officer. Now, at the subdivisional level, that is at the taluka level, we will be having the additional director health or family welfare, that is the ADHO. Now, these people will be like converting the hospitals into like something what we call it as the CHCs. Now, what they do basically is it will be responsible for the health of 80,000 to 1,20,000 people, or roughly or so. It keeps on changing so that all the basic services, that is, and the main health branches are included in it so that they are being given effective referral support. That is about the community health centers. The next after that is the primary health center. As we all know, that is the word PHC. It's very famous, famous among us. Like what exactly it will be doing, what exactly, we know the 5 cardinal principles, everything is there. But what exactly happens over there is it's considered as one of the first referral units, and then it will be responsible for the people of like 30,000 or 40,000. And if you go to a rural area or a hilly area, it will be less. Now it will be having one medical officer and 2 assistants and other supporting staff to make sure that it meets the basic needs. And now moving to the last component, that is at the tip, is the sub-center thing. That is, it is for a population of just 5,000 or even less in any goes to rural areas. So what basically happens is, it is like we compartmentalize and divide it into smaller components so that everyone in the country gets a part of what we call it as a health for all. And no one is left apart when it comes to the health. Now, in India, we have got something known as Panchayati Raj. It is more or less similar to what I've been telling right till now. It is basically again divided into 3 parts. It's the Panchayat, Panchayati Samati, and the Jilla Parishad. Like it's just the village, the block, and the district level. You can see it in many states in India. What exactly happens is the Gram Sabha, that is at the village level. So what they do is they just make sure about what exactly happens in a particular group of villagers, who just assembles and make sure what are the administrative activities happening. So it will be like 15 to 30 villages are covered, like 5,000 to 15,000 people, and they plan according to Then they plan according to what is needed, like what all materials do they need, or how much money is required, or what are the needs of the people, and accordingly they plan it forward. So basically, the Gram Panchayat will be the members will be holding it for a period of 3 to 4 years. There will be a president whom we call it as Sarpanch or Mukhya, a deputy of him, and a secretary. Now, what all do they do? The first and foremost thing is about their administration, like public health, sanitation, economic development, and social, like how exactly a government office. Now, coming to the block level, we call it as the what do you call it, as centralized area. It will be responsible for more bigger component, like 100 villages, more like 80,000 to 1,20,000 people, and it will be run by the Panchayati Raj agency, that is the Panchayat Samiti. Again, we will have the sarpanch of all the areas, block MLAs, MPs, and the representatives from all the caste and the societies. Now it will be headed by the block developmental officer. Now, what they exactly do is they just compartmentalize what is happening for all the 100 villages, and through the deputy, like the Gram Sabhas or some, and they channel it through the other components also. Now, and the BDO, the block developmental officer, will be giving for the tech assistance and the one engaged in development. See, when it comes to development, you can not just help. It will be the other developmental aspects also, like constructions or any other roadways. Everything will be taken care by this level. And finally, is the Jilla Parishad or the district level. What they do is they just go for the coordinating, just like we compartmentalize like national, state, district, and also same is this one, but in a different way, involving more people. That will be the next component. Then we have the one of the main component, like the worker, who does actually the thing, who may ensures that each people in each corner of the country receives one of the grassroots level worker, that is the village level worker, or we call it as the Gram Sevak. He'll be in charge for 10 villages. As we know that the branches of a tree, it keeps on going to make it smaller and smaller. So this is one level of worker who is responsible for 5,000 to 6,000 people, and who keeps a very close contact with the members of the family in the village. So what he does is he comes to know about what are the needs of that population, what all they require, and he is like more or like a multi-purpose worker, and he ensures the proper linkage between the people and the higher authorities. He will be reporting this thing to the Gram Sabha, and all the Gram Sabhas will be going to the higher authority, BDOs, and then finally to the Jilla Parishad, like that. So that is the linkage, but he will be the person who makes sure that each person receives what is actually required. The next set of workers is the village health guides. So what it is established in the long back, it is to ensure that they can take care of their own health. So the idea was that people's participation, the people should see, even if you have been investing crores and crores of rupees on healthcare systems in the world, I think if people don't come and utilize it, say for example of our vaccines now, just take 9 months back, the vaccine was available, but no one wanted to take it. But when after the second wave, people were running behind the vaccines, just like that. If people are not participating, there is no point in it. But people should be made aware what are the advantages, disadvantages of a particular healthcare system, and based upon that only they will come forward. See, now in India, people know, okay, what is the advantage, what is the disadvantage of it. That's why people are voluntarily coming forward. So same is the case of any healthcare thing. The people should be made aware and they should come and participate. So these village health guides are designed in such a way that they make sure that the people come forward to participate for their own healthcare needs. Now, how they are selected is like it's from the local community who are permanent residents, preferably women. And as this thing, they should be able to read and write with minimal formal education, and they should be accepted by the whole of the community. and they should be able to spare 2 to 3 hours of per day for community health work. That is the most important component. They should spare, because you cannot ask the person to do the entire work a whole day, but they should able to spare 2 to 3 from their every day. Now, how do they are trained? They should be trained at the primary healthcare center, like for 200 hours over a period of 3 months. And once they finish it, they will receive how they have to work and some kit of medicines, like a basic medicines on how to, even though not just allopathy, but also the traditional. Now, why traditional medicines? Why? Because see, when you go to the interior parts of India, you can see still that people believe in traditional medicines. That is why these village health guides are even now trained also for giving allopathic as well as traditional medicines before they being referred to the higher centers. Now, it's an old data, but the basic achievement is to achieve that it is one health guide for each village or 1,000 population. That is the main ultimate aim of getting the health guides. Then the next one is we have the oldest one, that is the local guides, whom we call it as traditional birth attendants. What they do is like the rural health programs, they just make sure that the women who are being trained to know about the maternal and child health, what all skills they require to take care of the mother and this thing. So what they do is it is being trained for 30 days over a period of 2 days in a week. And the rest of the days they accompany the healthcare worker and they go for the further field training. And after completion, they just make sure that they have a kit, delivery kit, what all is needed to make sure the safety of the mother and child. So, and the aim is one local guide for each village. Then we have the next group of workers, the Anganwadi workers. Angan means, in Hindi, the courtyard. So what is like, it's like our own, we call it them as our own. So what they do is like, it is usually for a population of 1,000, and there are many programs under which it is being run. So what it is expected from them, it is like, it should be a very familiar person who knows in and out of that community, so that that person can go, preferably a lady, it will be the going to the community and they come back with what is required, what the people need. So they should be selected from the community where they are going to serve, and they should undergo the training, not just about anything. It is going to have to what the health, nutrition, child, and further how they to assess them. And the next they should be knowing about the health checkup, immunization, nutrition, health education, and about the school education also. And what are the other referral systems? So till now I was just talking about the basic ones. Now I'll just move little part from my topic. We'll just go to the volunteer other agencies which work in India. So first and foremost, we have the Indian Red Cross. It's again in general, what all things they do. As we all know, it's like scattered throughout the country. They make sure that there is relief works, medical supplies, maternal and child care, family planning, blood bank, and the first aid. Then we have the Indian Council of Child Welfare. It is sorry, it is mainly for the child. So it is make sure that the child is developed physically, mentally, and spiritually, and just to make sure that they attain a health where they can lead their own lives in freedom and dignity. Then we have the Tuberculosis Association. It's a campaign being run every year to raise the funds and to train doctors, healthcare workers, and everyone for the promotion of and doing health education to eradicate TB. Then we have the Bharat Sevak Samaj. Again, it is the prime aim of this is to help people to achieve health by their own actions. Compared to others, the Bharat Seva Samaj makes sure that the people they are being trained, they are being educated to make sure that they achieve the health in their own ways and efforts. They don't have to depend on others. Then next we have the Central Social Welfare Board. Again, it's an autonomous association which comes under the Ministry of Education. Then, of course, we have our professional bodies like IMA, IDA, Nurses Association, and so on. Now, what exactly these association do? Now, these are involved in each and nook and corner because it's a huge task force. They can be involved in not just only conducting the conferences, publishing, research, and everything, but also to mobilize the education as well as the healthcare needs by conducting camps or going through the even during the natural calamities also. Now let's come back to one of the other component in healthcare system, that is the NRHM, that is the National Rural Health Mission. It was, even though it was established in the year 2015, it was said it is to be only for 7 years. Still, it is being running successfully because it is one way of achieving economic and social development throughout the country, irrespective of anything. Now, what exactly it was, how it started? It just started with 18 states, like states of Bihar, Jharkhand, Madhya Pradesh, Chhattisgarh, UP, Uttaranchal, Orissa, Rajasthan, Assam, Arunachal Pradesh, Manipur, Meghalaya, that is the eastern states, and apart from that, Himachal and Jammu Kashmir. And what it tried to achieve was the basic healthcare delivery. What is basically needed for the population? And it shows that the different determinants of health, there are various determinants of health. Now each aspect is being covered irrespective of what it should not attain or should attain, like nutrition, sanitation, hygiene, safe drinking water, the physical needs, the psychological needs, everything, and included the traditional medicines also, to ensure that all is going for the common aim, that is health. So what it was wanted to achieve is accessible. Everyone should have an access to it. Affordable, accountable, effective, reliable primary health care. And it should bridge the gap between the existing rural and the urban healthcare systems, along with, and what we call it as a huge workforce, that is the ASHA, that is the Accredited Social Health Activist. Now, what is exactly is this ASHA program? It's nothing but it's one of the biggest workforce what we have at a very, what do you call it, at the basic level. It's usually women who are resident of that village, 25 to 45 years. They have a formal education, a good communication skills, and leadership qualities. Now, apart from the other workers which we discussed so far, this is one thing which makes these people apart, the leadership qualities, because they make sure that the people gets more actively involved in the activities what they are being discussed. And usually it is like one ASHA worker for 1,000 population, and if based upon the area, it will keep on changing. Now, what exactly do ASHA workers do? The first and foremost is creating awareness and information. They explain, since it's a very known person for the people, so they can explain it in their own words or their own ways of explanation. Not only is about the nutrition, the sanitation, hygiene, and existing healthcare systems, and how to utilize them at each point of time. That is one another aspect. The next is counseling women for their related to pregnancy, like birth preparedness, safe delivery, breastfeeding, immunization, contraception, prevention of infections, child care, everything. Then mobilizing them. That is the next aspect. See, unless and until the people mobilize and come forward for health services, it will not be successful. So it has to, the people has to be mobilized. They should come forward to each of the centers, like whether it is an Anganwadi or a sub-center or a primary healthcare center, for immunization or checkup, or even for the nutrition and other services which is being provided. Then the ASHA worker works along with the village health and other communities, that is the Gram Panchayat, to make sure that the planning is done in a proper way, especially in a rural setup. Then the next is accompanying the pregnant lady. See, when the ASHA workers keeps a record of what all things, what all medications or what all is needed for the pregnant lady, how they are going to be transported, when they are going to be admitted, and all these things. And even after the birth, whether the child had the vaccinations, which all vaccines did they miss? If they miss, how they can get it? If the vaccine is not available for the baby, where they should go? All those things they keep a track of. This ASHA, it's the responsibility of the ASHA worker. Then they are, since they are being trained to give the minor treatments, a small things which they can do at their level, especially in case of dots or in case of first aid or other fever or diarrhea. Then also ASHA worker is like a depot holder for the basic things like or ORS solution, iron tablets, or any other pills and thing. And they should keep a record. They always keep a record of the births and deaths. Suppose it is not being reported, they ensure that it is being reported and it is being recorded properly by the government. The next part of the rural health mission was the strengthening the sub centers. The sub centers, how they can be like, see, the national rural health mission was to ensure that the last three ending points like the sub center, PHC, and CSC, and the grassroots level, the people who get directly involved. So NRHM becomes ASHA workers, then we have the sub centers, then the PHC has to be strengthened, and finally the CHCs. So till now we were talking about the next important thing, that is the ASHA, and next coming to the sub centers. So what should be there in a sub center to make sure that everyone achieves a proper health? The first one is make sure that there is a supply of essential drugs. The medications come in proper time and it is being given throughout. Then additional staff should be there, and funding for the staff members as well as for the administration. Then, like not only just medications, but also for the other things like preventive or promotive, like curative, or any immunization syringes or any other thing that is required. Then coming to the primary health centers. Now here, the primary health centers are being converted or strengthened to as the 24-hour referral unit. Till then, it was just like, it will not be like it will be opening and closing. But here, it will be working as the first referral units where it will be running 24 hours, and it will include all the faculties, like not just allopathic doctors, also the Ayush doctors. So it will be having more staff members, and it should make sure that the felt need of the population is met, and it makes sure that other non-communicable diseases also are in control. Then CHCs, that is the community health centers. Here now it will be like a bedded where they will be admitting the patients, doing the surgeries if needed, and it will be taken into the next level where they are being doing proper treatments with adequate infrastructure, staff, and equipments. And it will be according to the Indian Public Health Standard norms. So here we call the concept as Rogi Kalyan something. It's like a major administrative step in the CHC to make sure that all the needs is met at a proper level and the cost is also kept in check. So I think you might have seen this particular picture in your textbook, park. Like what happens is this pyramid for the NRHM. At the top, we will have the block officer, and then the block level hospital, and below that, that is your GPs and the PHC level with the staffing pattern. Then the Gram Panchayat with the healthcare sub center levels, then followed by the village level, that is the ASHA workers, health sectors, and other ones. So as it goes down and down, lesser number of people are being met, or if you go up, more populations being covered by the higher authorities. Now coming to the oral health. So till now we were talking about not general health. On oral health, when it comes to oral health, mostly the healthcare system happens through government dental colleges or government medical colleges with dental wings, or district hospitals with dental wings, CHCs and primary health centers with dental wings. But it is, as we go down in the step, like PHC and CHCs, the number of dental units will be less. At district level, you can expect, but at CHC and primary healthcare centers level, it will be less. Now, coming to the non-governmental, private dental colleges and medical colleges with dental wings will be there. Corporate hospitals as well as charitable hospitals with dental units will be functioning. Apart from that, we have the private practice. That's a huge workforce. That is the private dental practitioners, private dental hospitals, or private medical hospitals with dental units. Apart from that, we have got the various indigenous system in India. Now, it's the other organizations like the apex body for us, the WHO. We have been hearing this word. We have been seeing Dr. Tedros for the past 2 years plus, the WHO. So I don't have to talk much in detail about it. Everyone will be knowing in detail what exactly WHO does. But just a quick recap. It's totally an independent one. It's the largest and the non-political self-governing unit with the headquarters in Geneva. It was established on April 7th. That's why on that particular day, it is treated as the World Health Day. So in general, if you speak, they'll be involved in the prevention and control of diseases, family health, environment, research, health literature, ls like that through their publications. Everything what they give is information that they give is free of cost, like their publications and everything. And they do cooperate with other organizations to make sure that the health is achieved throughout the world. Apart from that, we have the UNICEF. It is for the children. It is like for the child health, family, and the child welfare and the education of the child. It is the part of the UN. And then the World Bank, the funding part, where the money comes for the funding agency, the agencies to work through. And it will be making sure that through various projects, you cannot give a huge money to one particular organization. They'll be running as projects to small things to ensure that the money is distributed at an even manner. Then, of course, the larger version of our Indian Red Cross, that is the International Red Cross. It is basically dealing with the war and everything. But even though now it is dealing with the health as well as the education also. Then the Rockefeller Foundation, again, it's for the public health and the medical education. And of course, it is for the promoting the well-being of the mankind. Now, this is one thing which you might be familiar also with is the Global Child Dental Fund, GCDF. It's a UK-based charity organization. It makes sure that the disadvantaged children are not deprived of their oral health. See, as we all know, dental decay is a preventable one. But if it is not unattended, it will lead to major problems. So to avoid that, this particular charitable organization makes sure that it doesn't, all the underprivileged or the underdeveloped areas, children are not deprived of their oral health. So what exactly this GCDF do? The first and foremost is making a cadre of senior dental leaders. Senior dental leaders, they train people and they ensure that they are able to give the measure the dental care is given at the various levels, like novel and local, national, or global levels, and then improving the health, not just curative, but also preventive and health education. And finally, increasing the responsibility of the professionals, like emerging generations. The senior leaders ensures that the emerging generations do come forward to do oral healthcare needs and treatment for the people. So this is what we call it as the Global Child Dental Health Task Force, that is the GCDTH of the entire thing. But a similar pattern was devised, what we call it as the Child Dental Task Force. So it is it's nothing new in concept. It is just the same thing, but we are just rearranging it. Like the public dentist, the public sector professionals, private and public partnerships together at the proper leadership will become the Child Dental Task Force. And through this, various levels of our care systems like primary, community and tertiary healthcare system, We make sure that the programs are there for the poor and needy, or community programs for the mother and child, school-based programs, and ultimately we are looking for the basic, only the basic treatment like oral prophylaxis, restorations, fluorides, pit and fissure sealants, and finally education. So ultimate aim is to ensure that is a quality dental care and they do not experience preventable dental decay. Dental decay is preventable. So we have to ensure that it is, they do not experience it. So I think I just covered the first part of the what I have to discuss, that is the agencies, what all things, what all workers are being involved. Now coming to the my second part of what maybe is the survey, like how exactly how you're going to get the data from people. See, you before you go into you say you're going to tell in the government, I have got like 10,000 people are there in a particular village, they need to be vaccinated. As we are making simply making a statement. Now we don't have any information related to that, whether they have been already been vaccinated or whether they actually need the treatment or anything. Now let's take our dental example itself. You're going to tell that I need to do the dental treatment for all the 1 lakh population in my particular village. So you have to tell how many dental caries is there, how many periodontal disease, how much is the percentage, what is the prevalence of it, and what all you require, how many workforce is needed, how much money is needed, is there in a provision for if there is no electricity, what is the alternate for it. All those things has to be evaluated, and to get certain information is what we call it as the survey, and then we do the planning part. So we call it as a non-experimental investigation. To investigate it to find out what exactly the population needs. Like you collect the data, you analyze it, and you determine which disease is the priority, which one is an issue, or which one has to be taken into consideration. All those things, and you just systematically arrange them, and then you intervene. But in survey, we don't do the intervention, we just do the investigation. And so what we do is we do the calculation part, that is rates, incidence, association, and correlations, and get the information related to the oral health as well as the general health. Now, and the next part is like which all resources have been used, which all resources are not used, which resources is needed, which resources is not needed. Those things we, and then we find go for how exactly the work has to be gone. Then we go for a survey, which is to make sure that what is actually required. So there are various types of survey. The first and foremost, what we call, it's also a short note for you people, that is the Pathfinder survey. It's nothing but a practical economic survey, and some method. What we use is stratified cluster sampling technique. So we have got different age groups, and we, according to the age group and the cluster, we arrange them, and then you go for the survey. See, let's take an example of a district or a particular state. The entire population is 3 crores, and you have been told to do other survey. You cannot get the information for the entire 3 crore people. It will take years. So what we do is we just take a representative sample. Now, how exactly we are going to do the representative sample is through proper sampling technique. So one of the most economical one and the practical way is a Pathfinder survey, and it will make sure that there is a index age group and a cluster is made. So before that, we do something what we call it as a pilot survey. Pilot survey means a small one, a smaller version of what exactly we are going to do. So in that one age group, we select is always 12 years, and the other ones is any other age group. So here it will be only just a minimal amount. A minimal amount of people is taken into consideration, or minimal amount of data is obtained, but we are going to get what are the any issues are happening, or is there any other issues which is there, or is there any hindrance that is going to happen, or how much is the cost, is the cost that we calculated, is it correct or not. All those things we come to know in this one. So in the National Pathfinder survey, we make sure that the index age groups are selected, and then we go for the data collection. So these are the age groups, that is 5 years, 12, 15, 35 to 44, 65 to 74. And in each group, we make sure that 25 to 50 people are considered. Now, why exactly is 5 years old taken into consideration? Because it is purely primary dentition. Here, we're just looking for the primary dentition status, nothing related to the permanent dentition. 12 years old. So here the child is left the primary and they are started with the schooling, and it is like except third molar, all the permanents have been erupted. And one of the most interesting feature, that first permanent molar has been in the oral cavity for 6 years. So you will come to know what is the aggregated caries thing content related to it. That's why we call it that choose age as the global monitoring age for caries, because that it's been in oral cavity for a minimum of 6 years. Next is 15. Now here, all the permanents have been exposed for a period of 3 to 9 years, and you come to know about the periodontal status, like in adolescence, like a gingival recession or something, not like your periodontal in this thing. The next is 35 to 44. It's a standard age group. Here we are not looking just for caries, but periodontal status as well as the general effects of healthcare. So suppose a treatment effect, whether it has happened or not, those things have been taken into consideration. Those things we can calculate using the 35 to 44 years. The next is 65 to 74. Here we are looking for the geriatric population. So here, what we are looking is the age lifespan, like elderly population, root caries, or the periodontal status, or their prosthetic needs. What exactly they need, or what more is needed for them, or is there anything apart from that that is required? So that is why this age group is selected. So these are the steps in survey what we generally follow, that is establishing objective. Why exactly you need to do the survey? What sort of information you need to collect, like whether it is the dental caries part, or whether it is the overall dental part, or whether it is the health care, or you need to know the financial status, everything. Then next is how exactly you're going to do, how many people is required, how much instruments is required, how much amount of money is involved. Then the next step, that is selecting the sample. How much people, like how you're going to do the sample size calculation. Like if we have an already pre-existing data, we go for a statistical software and then you calculate a sample size. Otherwise, if it is not there, you go for the census and then you calculate from it. Then doing examinations. Suppose if it is the oral examination, which method are you going to follow? Type 1, 2, 3, or 4. Then analyzing the data. Once you collect the data, you have to analyze it. Like how much is the percentage, what is the rate, ratio, what is the association, what is the relationship between it, and all. Then finally, drawing conclusion and publishing the reports. You have to conclude what is that area, which area is lagging, which area is need to be focused, and then finally reporting the data. Now, surveillance is a part of it. It is like continuous periodic collection, analysis, and interpretation of data. It is like we are on. See, when it comes to survey, we just start and we have a stop. But surveillance means we are just keep on continuing the data. We'll collect, add on, interpret it. I think you might have seen in the news channel every day a graph showing increase or decrease of COVID patients or the hospital rate, all those things. That's known as a surveillance part. So here it is more control strategies, but it is really extensive and exhaustive also. Like a new disease pattern, how the trends are going, whether it is increasing trend or a decreasing trend. Even it takes years for some disease. Like for example, our COVID pandemic. Since 2019, we have been actively following it. How many cases have been reported, which all areas have been affected, and so on. And then finally, we just make sure that whether it is being controlled or not. So, and for effective this thing, you have to make sure that even the oral health survey, The last oral survey happened years back. It's almost 10, 20 years now, but no further information is there. So we need to make sure that all those things happens on a regular basis. So is there any questions which you like to ask? You can ask now. Or is there any
Okay, so that was in fact a very nice, exhaustive presentation by Dr. Vinej. As you can see, I'm still traveling. So, any questions for Dr. Vinej? I think specifically, if you because it's been covering a lot of aspects from the various types of healthcare workers to the
yeah,
systems and global organizations as well.
yeah,
So
the
please do.
content which is given to me was really big. I was like, how to concise it into like 40 minutes. That's why I
Yes,
was,
no, no. I think that was really well done and concisely done, mainly because you covered the overview of all the topics which is relevant. So that's the whole purpose of these rapid revision sessions, because most of our audience and PGs and anyone who attend this, right? So they do are aware with the background. So it's not like we have to go right in the beginning, go in detail for all the topics. So this is what exactly was required.
yes.
Okay. Any questions from Doctor? Could you stop sharing your slide from your end?
Yeah,
Yeah. Okay. So, do we have any questions for the audience here?
yeah, I got one question when it come. Mention the
Okay.
challenges of primary
Yes, Dr.
healthcare.
Vinay. We have a question in the chat box.
Yeah,
Yeah. Please
the
go on.
challenges. See, basically, the challenges what we face is because the first is infrastructure. In most of the primary healthcare centers, you can see the infrastructure that is being provided will be running always short. It's always running short of what we actually need. That is one of the biggest challenge. For that thing, people have to come forward and ask the government to provide more. See the, as I said, the workers will be there. You have to make sure that the healthcare workers are met. You have to ask, then you have to interact, and then you have to put forward to the government what exactly is needed for your population. That is the first challenge, infrastructure. Let's take the example of our dental alone itself. The first thing is like in most of the PHCs you go, you will not see a dental thing. That is one this thing like people have to go back to the higher centers or to the private hospitals or clinics to ensure that the the oral healthcare needs are met. So that is one of the biggest challenge of a primary healthcare. The next is the fund for it. See, as you all know, in any budget or any health policy, if you look, the oral component is very less. It's very less. The money allotted for the healthcare needs is very less. So you have to mobilize in such a way that the healthcare needs are met according to the infrastructure as well as the financial part. Then of course the manpower, that's another challenge. People are not always ready to work. I'll give an example for it. NRHM do give postings for the dental doctors in most of the states, but as you can see, some people they either stay for years. It's given as a contract for 1 year, but they somehow use their influence and they stay for years. And in some places, no one goes at all, telling that it is a temporary job. So that is another challenge. I think to Dr. Arati, I think I have answered to your question. Is there any other question?
Yeah. Any other questions? Please do post it in the chat box. Okay. So, meanwhile, when we can get any more questions, I'd like to extend my heartfelt gratitude to Dr. Vinej for taking out time and conducting this session. Extremely pertinent topic because as public health dentists, students, and PGs, all of them need to understand what are the defined roles and how you can bring about, a certain change in healthcare systems and how you can bring about a certain change in the
Dr. Dancy?
Yeah, it was a nice presentation. Congratulations.
Thank you, sir.
I think Denzi is traveling. Probably you would have lost the connection.
Okay, okay.
Okay. Okay. Thank you very much.
Yeah. Thank you so much, everyone, for joining. If you have any queries, you can just message me up also, or you can mail me up your questions. Is there?
Okay, doc.
Okay, Dr. Dancy. Thank you.
Thank you so much once again. See you all very soon. All of you next Wednesday for the next session. Thank you all the PGs. Again, like I said, like Doc mentioned, you can always do write into us for any specific assistance. Goodbye, everyone. See you. Stay safe. Bye bye.